this one is going to be all about being like building on. It's really like building on the last couple of sessions and getting feedback from this time in more of the hospital setting, but relevant for anybody too. We're talking about co-design and again, forging partnerships, but being more than a vendor in the technology space, how to do that effectively in a hospital setting. So to do that, and this session, by the way, is presented by Informatics, who've been a great supporter for the summit. Thank you to all our sponsors and Informatics for this one in particular, because it's what brings these three participants together in terms of commonalities and a lot for everyone to get out of the session. So I'm going to bring on to stage, because I'll be moderating. There we go. That's where I do it. You'd think I would have learned by now by the end of this where to do it. But there we go. We've got David Ryan, Sue Sinclair, and Beck Ziffer. Thank you so much for joining.
Nice to be.
Great. Excellent. I'll give a bit of an introduction of everybody as well. Beck Ziffer is program manager specializing in designing and implementing and enabling technology in hospitals to improve health information management, operation efficiency, and patient outcomes, all things that we strive to do on day to day. And she also advises high-value digital and data strategies on health information optimization and benefits realization emphasis. So all really pertinent and relevant to this conversation. Sue Sinclair is Service Line Director for Cancer Care at Ramsay Healthcare. She's worked in strategic level in health for over 15 years, passionate about making a difference for people with healthcare needs, developing better ways to improve health and well-being and a positive experience. And lastly, no stranger to talking health tech now, it feels like, David Ryan, Chief Information Officer at Northern Health. So featured on the podcast recently and in a live stream. I think it was episode 174. I usually know episode numbers like my children, but that one I'm pretty sure was set 174. And so he's experienced director, executive, CIO, strategist, and ICT architect, experience in health, government, and service sectors. So lots of valuable insights to come from this session. So let's set the scene. We're talking about the importance of forging good relationships, particularly between hospitals and technology vendors. And we're certainly taking, the hospital and health service perspective here in this conversation. Tell us from your experiences, what, each of you perhaps will go around, we'll go David and then Beck and then Sue. Tell us about your own experiences, about what you've attributed some positive successes in terms of those partnerships with vendors and hospital setting. David.
Thank you. Thanks, Pete. Awesome summit sessions that you're having. And there's a lot of parallels with the last session, actually, particularly around partnership. So partnering with vendors. So saying, although we might be a customer and we might have, a very strong, either large or small vendor, forging really strong partnerships with those vendors rather than just a customer-supplier relationship, I think is important. And we've certainly seen that in the hospital sector, where you get a combination of, working through problems to try and solve some clinical problems as well. So we might have, for example, we've recently started up a virtual triage environment for our emergency department. So in COVID times, obviously the north of Victoria is undergoing a bit of a burst at the moment with COVID. So as a result of that, we've had to stand up a virtual emergency department. Now that's meant we've had to work really closely with our vendors to build solutions that serve that requirement. We actually had a company over in the UK that we worked closely with, and it was actually the clinicians that worked closely with the company. Now, what was interesting about it is this had not been attempted before, particularly in Victoria, and it uses like an algorithm in order to be able to try and smartly triage the clientele. Now, that requires really close relationship to be developed between the clinicians themselves and those that are actually tweaking the algorithms to make it work. So, things aren't always smooth sailing and they have to be worked through.
Yep.
We certainly have had really good outcomes from that particular implementation as well.
Excellent. We might come back to that one too, but I'm keen to hear from Beck. I just noticed the dog in the background there too.
The realities of life at the moment.
Yeah. And what about yourself, Beck? Go set the scene.
Yeah, well, look, I've been lucky enough to work with a few different vendors at a few different hospital groups who we've managed to have great relationships with and really build their products and the hospital's objectives out. One of the good examples, I think, really involved, I suppose, the people that are on the floor, and we're allowed, I suppose, access to them, and they're allowed to be part of the process. And I think that really helps. So you get the knowledge of the people that are doing these tasks day after day after day, and just thinking for them, from their perspective, they're thinking they just have to continue to do it that way. But by working with the vendor and just realizing that those functions that they could build would be useful not only for this group, but for other groups, it really is a win-win situation. So being allowed to work with vendors and to really build their roadmaps with user groups from other hospitals and people who are really working on the floor, it's just it's such an advantage for everybody. It really helps cut through. I mean, I sort of work a lot in that, the back end, the basement with health information and the data that sort of starts at one end and comes out the other end, and really being able to work with vendors to make use of that data so it's not duplicated and people aren't doing things 5 times, even with really basic systems. So it's just been really powerful. And it's really great to get everyone on the floor involved, because then that whole change management process becomes a lot easier as well, because they're a lot more accepting. It's not saying you can do everything, but it is saying that even just allowing some of those small wins turn out to be big wins.
Yeah. No, perfect. Thank you, Beck. And, Sue, from your perspective, some of the, successful partnerships that you've had, what have you attributed the success to?
Yeah, I think, well, it all starts with the goal of having a partnership as opposed to, a transactional relationship overlaid with the product that's going to be rolled out. It just doesn't happen that way. And where it's worked really well, it's almost like you're bringing together experts in a particular area. So, clinical expertise on the ground, how it works in practice. You bring a vendor that has technical skills and knowledge and digital experience and drawing on their experience in other clinical settings. And then overlaid with that is I've been in several roles where I've almost been the bridge between the two. And so that's been really helpful to facilitate what it is we're trying to solve and how we collaborate collectively to achieve it. And each of us is bringing a level of expertise to that solution. And I think the other part of that is understanding what is the problem, that we're actually trying to fix, rather than trying to fix everything, and starting with that point and creating a solution that addresses the problem, but also looks to that end-to-end pathway, or how it fits into a much bigger system. So I think all of those things add value in making a partnership effectively. The other thing that I would add is, and it's come through in some of the other sessions, it's around trust, honesty, having those frank conversations and knowing when things are not going well, that you actually address them, talk about them, how we're going to resolve it, makes such a difference.
Yeah. No, such a good point. And, the point that you made as well around, solving for problems, not bringing solutions first, is something that's come up in some other sessions as well. I guess to think about, to draw on all of your experience and thinking about when things haven't gone well, is it as simple to say it's when those things don't happen, that's when, these partnerships fail? I mean, David, from your perspective, when things don't go well with technology and healthcare, why is it, and how can it be avoided?
Yeah, often it's sort of reported by the end user potentially, that they identify something that's not quite right or doesn't meet their needs. But probably more often than not, it's some technical element that's not working as it should. And when that happens, it's a combination of, internally, groups tend to come together, they complain to IT. IT then might say, okay, well, we need to escalate this. Early escalation of a problem, I think, makes an immense difference. So going to the MD of the company or going to the top tier of the organisation to actually have a really frank conversation about what's wrong. Now, that could be to do with project management, it could be to do with the architecture of the solution, or it could be something as simple as, there might not be enough resources at the vendor side, or it could be a combination of resourcing at the vendor side and at the hospital side or the health service side. All of those elements can cause you enormous problems if you don't sort of nip it in the bud quickly. So escalation to the right levels certainly makes a difference. And having those free conversations about what you each can do to change things, that also makes a significant difference.
And Beck, seeing it from a few different perspectives yourself, what about you?
Yeah, no, I think it's about that too. And also those things, when things go wrong, a lot of it is to do because sometimes it was over-delivered, I suppose. The vendor gets in there and they say they can fix everything, to Sue's point before. And I just think it's about being transparent. I mean, no one really expects all their problems to be solved with a magic application. So don't promise it, and be really frank about what it will do and what it won't do, and what you might have to plan for to make it do in the future if you're allowed to do that co-design model. And from a hospital perspective, I think also being transparent about the fact that this commercial off-the-shelf solution is not going to meet all your needs unless you change a few processes or unless you also budget and govern for an ongoing relationship. So I think it's all very well to have an ongoing relationship and, be able to call out and have monthly meetings, but you've also got to be realistic about the budgeting for that. So, things that change do cost, like, whether it's big or small, but, and hospital budgeting is such a monolithic process that requires a lot of approvals. But I think also trying to plan for that is good as well. Get my dog off. Hang on.
Oh, good. And so, Sue, thinking about then, and I'll ask this to the other panelists as well, because we've got an interesting, I guess, cross-section of different experiences and representation on the panel, from public health to private, and NFP experience as well. So from a private setting, how do you find these types? Is there something unique to, say, private hospital settings, given that there could be vendors listening to this session, thinking about how to engage? Dealing with a private hospital setting could be quite different to public health and NFP. In your experience, is there something unique about that particular setting that should be front of mind?
I can certainly bring personal experience working in Ramsay Healthcare and the private sector setting. I think it is different, and it's unlikely that you will have the big system in place. And so from a Ramsay Healthcare perspective, we've taken a view that it is much more modular, rather than trying to overlay big platforms on very variable sites. So if I look at cancer care, we've got 27 different facilities, and the makeup of those facilities are all incredibly different, and the level of complexity is different. And, if you think about, we're working at the moment with informatics around multidisciplinary team meetings and treatment planning in the hospital setting. And what we found is 3 similar hospitals, their context is really different. The number of pathology providers that interface with those people that are, and the workflow of MDTs, all, but they're very different, and that and my theory is start small. So test it, iterate, test it, expand, keep going. And so our last bit, looking at really MDT with the hospital, test it, they wrote it, and then take our learnings. And now we're in phase 2 and we've gone to 11 MDTs and they're still really different, but we've learned along the way. So I think, that demonstration, taking things to scale gradually definitely makes a difference in the private setting. And knowing that it's not one size fits all and working out how we adapt to that.
Yeah. And building on this idea, and I can see Lucas, sorry, there's a bit of background noise there. I might just mute you there, Sue, just in case. But as Lucas mentioned here, prototyping is a great way to uncover some of those solvable or complex hurdles in these scenarios. It's interesting bringing up the concept of, giving small use cases and proof of concepts. We've talked about in the past, I'm talking health tech, sometimes, some of these technology solutions can almost be death by pilot for, some vendors where we'll say, hey, it's an easy way to say, well, let's do something. Let's do a pilot. So, from your perspectives, for pilots particularly to go well, what needs to be established so that they're not just, I guess, a big waste of everyone's time? David, did you have any perspective?
Yeah, it's interesting. We recently have gone through this where we've had a bit of an innovation approach to development. So our chief executive announced that he wanted some big ideas, and those big ideas resulted in sprints, sort of 8 to 10 week sprints, in order to develop up the idea. So it's not just simply, an idea of 1 or 2 people, and then you form a very small group. The idea is to involve as many people as you can, bring a lot of that, I guess, wisdom of crowds together. And then once you've done that, you can then start to work closely with vendors to try and, scope up the solution, prototype it, do it in an agile fashion. So it involves, the right people as well from a cross section. Northern's a good example as well of representing the whole care continuum. We've got really good connections to the community. So a lot of the ideas were about providing solutions that bridge that gap between clinical and the community itself. And so prototyping those solutions with the consumer engaged as well, that's also made a big difference for us, in actually proving the solutions out. So for example, that virtual emergency department solution had direct consumer engagement in there as well, helping us to design the solution so that, if someone makes a video call or a phone call to our virtual triage system, that it actually has a real person that answers the call. And they felt that was one of the really important parts. For them, it had to be a dynamic solution that wasn't just, someone having to be fearful presenting to a physical emergency department in the middle of COVID. So, certainly involving the consumer in that made a very big difference for us.
No, that's so true about closing that loop and having that consumer perspective. Again, it's come up in a couple of these sessions. Beck, any additional thoughts from your side, seeing, different sides of the fence in terms of how to ensure that pilots are indeed successful, or at least do what they're supposed to?
Yeah, I think, like Sue said, I think working for a lot of not-for-profits, the same sort of strategy applies in that they're never really going to have the funding model to be able to buy a large product. So that pilot model is a really good one of getting in, seeing if it works, and I suppose, as corny as it sounds, but realizing those benefits. Like if it can show a benefit, then people are really happy to adopt it and slightly manipulate it, site by site, according to those processes. But I think that it must be clear on how to measure those benefits. Like really, is it a revenue benefit? Are we going to, be able to optimize, the coding and billing and get a direct monetary, funding advantage? Or are we going to just stop duplicating and thereby make someone's, job a bit easier and get the information where it needs to go a bit quicker? So just being able to really, I suppose, articulate what those benefits are going to be is just really powerful. And it's something really concise that you can take to, the guy that is going to sign the bill to move on to the next hospital. So I think just being really clear and getting a foot in as well. Like I'm sure Sue and David have seen, when clinicians can't do what they want to do, they're going to go out and try and do it in another way. So it's a lot better for a hospital organisation to be on the front foot and to allow that kind of pilot model to exist, because otherwise it's going to happen, and then all of a sudden you've got data everywhere, and you've got security issues, and you've got unhappy clinicians and patients that could do with better care. So.
Yeah, it's an interesting dynamic, isn't it? Because often from a tech vendor perspective, and not always, but if it's a more innovative or novel solution, then it means from a hospital's perspective that the natural thing is, well, let's demonstrate that it works. So let's do a pilot. We've got all these resources to do a pilot. Then from a vendor's perspective, they might have a couple of devs. It might be a secure solution and it might be, robust, but in terms of people and the ability to run a little pilot might not be, be there. So, I think finding that middle ground in terms of the need to be able to demonstrate it whilst also working, I guess for what we're talking about is it comes to building a positive partnership to be able to find, well, where can both parties, give and take to be able to demonstrate what is a need. I don't think that need's going to be avoided. I think it would be remiss if we didn't take the opportunity to jump on Maggie's question here, which was to ask all of you, and I might go around about, from a general perspective, thinking about the biggest problems to be solved that within your setting, anything that comes to mind, like from the, that's needed from the technology industry that should be focused on. Maybe Sue, did you want to go?
Certainly in the cancer context, we have found the ability to bring lots of different pieces of information together. So technology really enables that integration. And the other part of it is different pieces of technology help to create that solution that you need. So, if I think about the MDT piece again, it's very much been around enabling a virtual meeting, underpinning by capturing the right data around best practice in treatment planning for cancer, and then collecting that information in a way that's useful to demonstrate from an accreditation perspective that we're able to, demonstrate best practice in cancer care. So it's enabled quite a few dimensions that we wouldn't have been able to do. That would have been very manual processes. So I think it's the ability to collect information, enable communication, and present it in a way that you just can't do necessarily with people.
And David, what about from your perspective?
Yeah, I've got a big one, which is solutions that span the care continuum, but also take the model of care change to a new level. So that's the focus in the I guess pre-COVID was probably about the person presenting, going through a process of whether it's surgery. Or whether they've got a chronic condition and being managed inside the four walls of a hospital. Pushing outside of those four walls of the hospital involves the entire care continuum. So that's primary care all the way through to the surgery that might occur. But then it's all the post-care and so forth. And as we know, a lot of care happens outside of the hospital, both informally and formally. So being able to bridge that gap, I think is certainly a very, very big problem to solve. Having said that, we need to start small because we can't afford these big solutions that try to do that. So whether it's a patient portal or, something that, a state solution that brings everything together, will sort of be long gone before they can come up with something that does that. So it's likely that we're going to need little prototype solutions. And I noticed that there was a question there about how to turn a prototype into something that's sustainable and can scale. That is certainly something we wrestle with all the time when we're prototyping. We are under government auspices as well, so we do have to follow procurement guidelines. That can also force some vendors out. So we've got to be able to be a lot more flexible with the way that we procure solutions too. But we certainly need to plug some gaps in the communications side of things. There's been some chat about Microsoft Teams and other products that sort of are so big that they're hard to wrestle with. But at the same time, I'm sort of seeing that our community need a way of interacting with us that we can't currently serve. So we have to build a whole heap of solutions in there that are probably smaller and more agile, and move with us, and move with the tech sector as it's evolving as well.
That's an interesting point about having, many small fish as opposed to one big whale to be able to achieve things in, little bite-sized chunks as opposed to one big giant solution, which by the time it's built is probably, past its needs, as you kind of alluded to. Beck, any final thoughts from your side in terms of what's needed from the technology industry?
Yeah, I think it's great points by David and Sue. I mean, from my perspective, I sort of see the fact that the challenge is the visibility and access of all this information really easily or in one place or, in a black box that can then spit it out to other things. I think there's actually quite a lot of information that a lot of sites already gather and have access to, but don't have the right type of access to. So even those hospitals that are paper-based, it's just the technology challenge is getting a way of having that information more accessible and visible. So whether it's in a data format or whether it's just I go into one system to see exactly where it is, whether it was generated there or whether it came from somewhere else or it was scanned in or it came through medical objects, or I know it's been done because there's a form called that in their record. So I just think that whole visibility is a really big opportunity in one place to make it easy, or in data to try and make it transferable. What that looks like, I don't know, but we just find that visibility and access is a big thing in the hospital and also remotely. So for our not-for-profit and private friends, the reality is the doctors don't work for the hospital or they work at multiple hospitals. They're essentially contractors. So they need to be able to get to their patients' data wherever they are in, of course, a very secure manner as well. So access is a big one.
Yeah. There's some great examples there, and we've got a strong vendor community within the talking health tech space as well as healthcare providers and others too. But thinking about then that next step. So just to start to close out the session, I think I might have mentioned that before, but as we wind out the session, thinking about solutions that can solve for some of these problems, or about taking that next step to, I guess, get in front of you guys or help solve some of these challenges. Is there steps or processes or suggested ways you can put forward for these solutions to approach you guys? I mean, Sue, is there any advice you can provide to vendors with these types of solutions?
I think it's reaching out and starting the conversation, building up the relationship, identifying what the problems are rather than here's my product. So I think it is sort of being in for the conversation and relationship development, and then addressing how it might fit in or not. And, one of the points in a previous session was, if it doesn't feel right or it's not the right fit, don't try and make it fit. I think it is about, it won't always be the right time, but important to understand what the problems are, how it might start to support those or not. And, circle back because, things change, or the timing might be, we've got a roadmap, this is where we're at, probably something we might want to think about once we've done these next couple of phases. So, that would be my advice.
Beck or David, anything addition to what Sue's neatly kind of summarized in that sentence?
I think she said it really well. So nothing much to add. Reach out. If you've got something good, then, tell the hospitals about it. They know what their problems are. And if you can help them, I'm sure they're happy to listen, but they might not be able to do something straight away.
Yeah.
Look, and then what we used to have is, probably the director of emergency or a physician come up to sort of the CIO and say, look, I've got this great product. I was at a barbecue and I saw this great product and had a great sort of demonstration. That then creates another relationship, which sometimes can be hard to manage, but at the same time, at least it starts the conversation. So we used to try and bat those away. Now there's very few barbecues, if any. So it's likely that it'll come via some other method, social media or something like that. And that's okay. But, certainly the advice is to vendors just to listen, listen to what we've got to say as well in response, and understand our organisation and the way that we're structured as well, so as not to pitch in the wrong way, in the wrong manner as well.
Yeah. No, look, that's some great advice. And sometimes, it's certainly a long game, and, relationships need to be built to be able to understand the problems to be solved. So I think, doing it with, the right serving first in mind. I think that often in, these commercial relationships, thinking with commercials first can often lead to not a great deal of success, but thinking about solving problems legitimately for the reason of all the reasons why we all got involved in healthcare, whether we're clinical or administrative or whatever it is, with those front of mind, I think we can do something meaningful. So we're going to close out this session. David, Beck and Sue, thank you so much for joining, and look forward to chatting more in the community later.
Thank you. Thanks, Pete.
Thanks.